From time to time, we ask students to prepare an operative surgery session also, indications, contraindications, preparation, procedure, and complications. And again, the session is moderated by a faculty. Sometimes we do have guest lectures by faculty, especially from related disciplines like anesthesia, critical care, medical oncology, radiation oncology, and others. The more than 200 videos of the previous JST sessions are available on the YouTube channel of Gastro University. Gastro University is a brainchild of my former fellow and now a consultant GI surgeon in Ahmedabad, Dr. Avinash Tank, and his IT team of Pinesh and Himanshi. They provide technical support for all the online educational activities of Jaipur Surgical Tutorial. And as I mentioned, masterclasses are an extension of the JST weekly activities. These are monthly masterclasses which are held last Wednesday and Thursday of the month, 7 to 9 p.m. India time. And we select a theme which is then discussed threadbare by a panel of about 6 to 8 panelists and moderators. This being the 19th masterclass, and all the previous masterclass videos are also available on the Gastro University YouTube channel. And then every year we hold a Jaipur Surgical Festival, which is a 2.5-day CME in Jaipur. We've already held 4 Jaipur Surgical Festivals, and the 5th one is scheduled to be held in December this year. The theme will be surgical, radiological, and endoscopic anatomy of the GI and HPB systems. Already done a masterclass on gallbladder cancer earlier, but this being an important topic, we thought that there are certain issues which need to be discussed again. And that is why we are holding this second masterclass on gallbladder cancer. The part 1 was held yesterday and part 2 is now with you. And I'm very happy to say that Dr. Anil Agrawal, who's the Chief of GI Surgery at GB Pant Hospital and who has made major and significant contributions to gallbladder cancer, agreed to be a co-moderator with me, and he will be with us for these sessions. And
thank you for the invitation.
Thank you. And the speakers for today are Dr. Biju Pottakkat, who's again a former fellow from SGPGI, but now the Chief of Surgical Gastroenterology at JIPMER Pondicherry. While at SGPGI, he authored a large number of publications arising out of the huge database at SGPGI. We also have Dr. Sadiq Sikora, who was my former colleague at SGPGI and is now the Chief of GI, HPB Surgery and Liver Transplant at Sakra Hospital in Bengaluru. And the third speaker is a guest speaker, a medical gastroenterologist, Dr. Usha Dutta from PGI Chandigarh, who again has contributed to gallbladder cancer. She's slightly busy with some personal work, and she would be joining us a little later in the course. So with that, I would request Dr. Anil Agrawal to make some comments before we ask Biju to go ahead with his presentation.
Yeah, thank you, Dr. Vinay, and thank you for the invite and for a topic which is so close to my heart. And I think we have been watching all your excellent experience that you have, and you have led the world in the gallbladder cancer. And so I think it's a pleasure to be a part of moderating this session. Yesterday was a very nice, informative session. And I'm sure today, looking at the speakers and you being there, I'm sure it will be a very enriching experience for all those who are participating. So thank you once again. And I look forward to the deliberations today. Thank
you. Biju, please start.
Sorry, my presentation is visible?
Yes, yes.
Okay. Thank you. So today we will discuss about the role of major resections in carcinoma of gallbladder, and we'll examine whether it is useful. So what makes gallbladder cancer an aggressive malignancy? Basically, most patients present either with mild symptoms or asymptomatic, and other spectrum we have symptoms of advanced disease. So malignancy, what we want is some sort of a moderate symptoms where they present early, but with symptoms. That doesn't happen too often in carcinoma gallbladder. And when they present, there is high risk of peritoneal and liver metastasis. and extensive nodal spread. Compared to cholangiocarcinoma, carcinoma gallbladder has more nodal spread, and even if it spreads so rapidly. And this tumor, which is very near to the liver hilum and just sits there and involve the other vital structures to the liver. That's why it is more aggressive. Why the management is very complex? Because of the biological nature, and these patients present with jaundice. So that also has to be tackled. And curative resection is not a simple surgery, and it needs a lot of knowledge, expertise, skills, and other ideas. And these cancer generally respond very poor to chemotherapy and radiation therapy, and also biological therapy, because these are all less vascular tumors. So every cancer, we expect surgery as per stage. So in gallbladder cancer, we have some ideas about this, and surgery for early gallbladder cancer provides good result, that we know. And surgery for metastatic disease provides poor result, that also we know. So there may be a role of R0 resection if it can be achieved in specimen in T3 and T4 tumors. And if the nodes goes N2 and beyond, the benefit is a little doubtful. But whatever said and we have read, we never became radical surgeon just by evidence. So all of our surgeries become safer because collaterally there is an improvement in perioperative care, increased technical skills. As we keep on seeing the liver resection, bisegmenectomies, lymphadenectomies, more and more people are venturing into aggressive surgery. Generally in abdominal malignancy, gallbladder cancer is not an exception. And we know that these surgeries can be performed with a very less mortality and acceptable morbidity. So we are also creating retrospective evidence without prospective evidence. So this is also contributing to the literature and scientific information. So can we depend T-staging on planning aggressive resection? This is the first question we want to answer. So T-stage is definitely going to affect your decision on surgery, and T-stage also going to affect the decision on neoadjuvant therapy, and T-stage also affects the idea of palliation or decision of palliation. But what really happens in the AJCC staging system is why we are not able to perform a very standardized aggressive surgery, because the categories keep on changing. The gallbladder wall, you know, that very small, very less thick structure within millimeters. But the T category changes very rapidly and across the various staging systems. And it also affects the nodal stations also. And ideas are keep on coming, and HSCC changes it very often. But still we are not clear. This is one of the publications specifically deals with the validation of eighth HSCC staging. And what this publication says is that 7th and 8th stage versions are really comparable. So even if we started subdividing, it didn't produce the desired results. And changes in end stage failed to improve prognostic prediction. And T-staging subclassification needs more validation. And even in patients with a similar T-stage or same T-stage, survival different end stages, we are not clear whether we are dealing with a different survival. So when we try to dig about the evidence which is generated in retrospective studies, we have two types of evidence in locally advanced carcinoma of gallbladder. The nodal stations are also included as locally advanced. You know that gallbladder cancer and the first nodal station is cystic lymph node. And even in many publications, any lymph node involvement is considered as a locally advanced based upon the survival prediction. But technically, it is not that we know. So these lymph nodes have created more evidence. Initially, any lymph node were considered metastasis, then became locally advanced. Now it is becoming more of a regional disease. The non-incidental CAGB, the problem is, as I told, the assessment of the thickness of the gallbladder, and with all its intricacies, the T1A, T1B, and T2 and T2B, it will be very difficult to assess in a prospective front by seeing the CT. And unfortunately, our aggressive surgical strategies are based upon this suboptimal investigations, and we may have to plan it otherwise. So this is what is going to happen at the ground level. Tumors are less than T3 stage, and some are T3 stages and some are T4. That is what is finally and going to get. But in the histopathology, we will get a clear information, and we want to derive the prospective strategies based upon what we can achieve only through histology. That is the one of the problem we find out when we talk about aggressive strategies in carcinoma gallbladder. Now, when we do an aggressive resection, the T front as well as the regional lymphadenectomy front, we have enough evidence to show that in last 25 years that once you achieve R0, then only there is a point in aggressive resection. If you doubt that R0 resection cannot be achieved, there is no point in proceeding with aggressive resection, even if the dependence is on chemo and RT. So that's not going to work. So that's why once we advocated a minimum bisectomy for all and extended lymphadenectomy, and when we approach this strategy through this strategy, and local and lymph node basing R0 might reach even up to 80%. So second question is, what local operation we are trying to do in aggressive front? Basically, we'll be dealing with the wedge resection versus a bisegmentectomy. So what we know today is cholecystectomy is an inadequate operation if performed prospectively. Cholecystectomy may be giving an incidental cure in very early lesions, and prospectively you cannot employ this strategy. So a question of negative margin on histology is basically sufficient even for carcinoma gallbladder. So when you target surgical negative margin, histological negative margins both are different. So you cannot achieve a negative margin by just targeting a negative margin of surgery. So you have to resect more. And margin from the tumor is not margin from the gallbladder. So when we talk about wedge resection, we sometimes get mix these two things. And wedge resection is 2 centimeters from the GB wall, and this cannot be translated into 2 centimeters from the tumor margin. So when we aim to compare the literature, what we wanted is cholecystectomy 2 centimeter wedge all over as a square specimen and anatomical bisegmenectomy. But what is happening in the ground level is people do other type of surgery as well. Cholecystectomy is less than 2 centimeter and compromise infundibular area, which creates a semicircular specimen, and non-anatomical liver is somewhat between wedge and bisegmentectomy. So what we should know is our evidence, what we are reading and publishing, include these patients as well. And when we conclude, we try to create evidence based upon what we have seen on the left side, exclusive two exclusive type of surgeries. So in the context of wedge and bisegmentectomy, we have to be very clear that what T stage we are looking at. So I already told the confusion the T stage, and till we are very clear about this approach, we will not be able to answer this wedge versus bisegmentectomy very clearly. So the principle of bisegmentectomy is we know that they attach to the segment 4B and 5. It extends there, and there are lymphatics there, prograde and retrograde flow is there, and satellite lesion extension are there. But these philosophies are, although biologically proved, this is not converted to practice in surgery. So there will be an institutional bias and surgeon bias. So bisegmentectomies are usually performed by liver surgeons, and they also perform combined extended lymphadenectomies, and if there is a focused multidisciplinarity. Because so what we know from this slide is it's more of a comfort, low morbidity and low mortality, which is prompting surgeons who do surgeries in gallbladder cancer to approach the relevant surgery. Whereas wedge resection is very common in GI and biliary surgeons, and they often combine with the standard lymphadenectomy. I'm not going to the conclusion of which is better. So large volumes may not be translated to highly focused approaches, because here we have a mix of biliary and liver surgeons. So this is what we do in bisegmentectomies, and a proper bisegmentation. So this much exposure, anatomical exposure to achieve an R0, to achieve a negative margin in the segment 4B front is not very clear as of today. But what we know now is you can go more into the liver, you can perform bisegmentomy with less morbidity and almost nearly less than 3% mortality. So this is going to be a safe surgery in future. But what is the advantage of bisegmentomy is, as you know, the gallbladder lies on the right side of the hilum. Once the segment is removed, it gives a very good clearance of the lymphatic area. So this area will be very clean, but if you do a wedge resection, normally we try to preserve that last part of the area away from the fundus, and we try to compromise on the lymphatic front. So this is what the advantage of a segment 4B5 resection on lymphadenectomy front. So it will give a very good idea about the bile duct and if it is to be resected as well. So the publication from the GBC hospital also shows that it may not, when you have achieved an R0, the wedge versus bisegmentomy may not have much difference. And this is replicated in various other publications as well, especially from abroad, but with a less number of patients. So general consensus says that both gallbladder bed resection and segment 4B5 are oncologically acceptable procedures provided R0 is achieved. So if R0 is achieved, major appendectomies are not superior to non-anatomical resection of gallbladder, but we should also know that non-anatomical resections are also anatomically defined operation. Then only there is a point in comparing. So our guiding statements, the way to look forward is if liver is involved or suspected to be involved, and if less morbidity can be achievable, a surgery which has potential to achieve more than wedging is a good approach. So naturally, we'll end up in somewhere near segment 4B5 or a little bit wider wedge excision. So in proved early gallbladder cancer, bisegmentomy may not be beneficial. Bisegmentomy also provide a good lymph node clearance, and in patients with jaundice, it helps to achieve a negative margin if hilar bile ducts are involved. So once the segment 4B5 is not there in the field, you can have a better negative margin on the, especially on the right side. So in the bile duct front, these patients, when they involve the bile duct, they present with jaundice, and as such, presence of jaundice is not an inoperability. Okay, so acceptable level of bilirubin also we have to see, and you know that when the bile duct is involved at the hilum by the carcinoma gallbladder along with lymph nodes, sometimes it creates a very difficult planes. Planes may be very fibrotic. That's why the some of the Japanese publications explicitly say that if there is a left side involvement, there is no chance of R0 resection or cure. So the hilar plane will be densely adherent. But when we talk about hilar duct involvement, we generally follow bismuth correlate classification, and your liver resections are based upon this bile duct involvement. So again, we are looking at R0 and negative margin, even in the bile duct. So, coming to the lymphatic front end operation, what is the extent of lymphadenectomy, how aggressive we can go, and how nodal disease burden affects decision for non-surgical therapies in the neoadjuvant settings or in the adjuvant setting. So what we know today is there are various types of spread in gallbladder cancer. Skip metastasis is also there, and also it may not follow a uniform pattern. And this intra-aortocaval nodes has a peculiar and specific role in gallbladder cancer. So it cannot be simply converted to a para-aortic node on the left side. So as we keep on improving the lymph node count, we also may need a more differentiation approach. But what we can approach is first echelon, second echelon, and distant echelon. Okay. So most of the surgeons clear the first and second tiers. So, and this area is with a lot of aberration. So as we know that these lymphatics follow vessels, and they may end up in a different station altogether. For example, the right hepatic artery SMA, that SMA becomes the second or first tier nodal stations. So in lymphadenectomy front, we should know that lymphadenectomy is beneficial in early stage. It provides a good staging. And when you plan an aggressive local operation because of a T stage, then it is better to excise up to tier 2 station. So you have a segment 4B5 resection along with a bile duct excision, then there is probably you can add it to a more aggressive lymphadenectomy to achieve an R0. And if you give neoadjuvant therapy, there may be some downstaging in nodal station, but that cannot be converted to your plan of extended. You cannot reduce your extended lymphadenectomy based upon response to a neoadjuvant therapy. So generally, some surgeons follow what is called a standard extended lymphadenectomy. Up to the intra-arteriocaval nodes, they go and take it up. So what we need today is more lymph nodes, and then only we can predict the survival and also the proper staging. So the therapeutic index, which is basically the positive lymph nodes into a 3-year survival. So what we know today is T1 has a better therapeutic index and T4 is worse. And the most important point is if more than 6 lymph nodes are resected, then there is a better therapeutic index for these patients. That essentially means that less than 6 lymph nodes is inadequate either to stage or to devise your surgical strategies in gallbladder cancer. So if low morbidity can be achieved, low mortality can be achieved, there is no harm in doing an extended lymphadenectomy. And the quality of lymphadenectomy also may be important, although evidence for benefit is controversial. If you go very near to the vascular plane, the yield is better. You can create a more number of lymph nodes, and the oncological benefit, there is a possibility the oncological benefit might be better. So you have different planes near the arteries and in terms of lymph node front. So try to go close to the vessels, and what we know today is do not just berry pick the lymph nodes. It is not going to yield the best histological evidence for you. So the difference you can see in this slide that if you go simply berry picking of the nodes, a lot of fibrofatty tissues left out, even lymph node pieces are left out there, and it may understay the patients or sometimes overstay the patients as well. So we need a very good clearance in the, especially in the celiac area and the hepatic artery side as well. So even the paratic node, the same phenomenon exists, and it is better to clear if you are the technical expertise as well as if you can create a low morbidity and low mortality. So this is a good approach. And you can create a beautiful plane like this, and then over the years you can generate evidence and tell the scientific world that it may be beneficial or may not be beneficial. So even the paratic area, there are multiple nodal stations, and what we know today is in the last decade we started venturing more into the paratic area. We do not berry pick the paratic area. There are specific areas even to biopsy. So we are becoming more knowledgeable about this area and its relation to the carcinoma gallbladder. Adjacent organ can also be performed, but when this is performed, you have to be very clear that you can achieve an R0 resection and the patient can come out with less morbidity and practically no mortality. Then only there is a point in doing an adjacent organotomy. So basically you are dealing with omentum, you are dealing with the duodenum, and also you are dealing with the colon. These are the 3 organs. And second involvement is through the bile duct and to the head of the pancreas. So you may end up in doing a pancreatoduodenectomy as well. So vascular involvement is more aggressive than hilar cholangiocarcinoma. Arterial resections which need reconstruction as a doubtful benefit. So there is a difference between an arterial resection and a portal vein resection. Arterial resections are more problematic, and main portal vein resection is better to avoid in carcinoma gallbladder unless you are subjecting this patient for neoadjuvant therapy, and this vascular front, there is a downstaging. So evidence is emerging that major hepatectomy or pancreatotomy, if associated, despite significant complication, it didn't affect survival compared to a comparative group. So a subset of patients, if you can achieve R0 even by major hepatectomy or HPD, they may benefit, they may land up in adjuvant therapy. So when we talk about neoadjuvant therapy has slowly getting established here, and it basically selects patients and prognosticate. And there is a survival benefit in node-positive disease and a technical downstaging, whether we can depend on technical downstaging to create a different approach in surgery. It's a little bit doubtful at this stage. And the most important point is in carcinoma gallbladder, even days count. So when a patient is coming with aggressive disease to you in OPD, your most important task is to divide the timeline when you are going to do a biliary drainage, when this patient is likely to land up in operation, when you are likely to give the first chemotherapeutic dose. If this cannot be achieved in the next 3 months, this patient is anyway going to metastasize. So even days count. So we need a rapid decision execution in the imaging, management of jaundice, rehabilitation, resection. And this is not the time to discuss about what imaging and how many imaging we need to perform. So in patient with advanced disease and possible nodal positivity, make sure that the patient is ready for chemotherapy in 6 weeks, at least by 8 weeks after resection. So if you create a more if you think that your surgery is going to create more complications and the patient is not going to land up in an adjuvant therapy because of bile leak, bleeding or liver failure, these patients will not receive the adjuvant therapy and they may eventually end up in not receiving chemotherapy and they will have the similar survival as that of any metastasis. So it is better that these patients are referred to expert centers to perform aggressive surgery and possible adjuvant therapy in a definite time frame. That's all from my side. Thank you very much for the kind attention.
Thank you, Biju. But I would voice some differences of opinion, and I will ask some pointed questions to you. Number one is you said that if you can achieve R0 resection, then it doesn't matter what T or what N stage it is. But the Japanese experience, when the Nagoya group especially, some 10, 20 years ago, they used to do extensive retroperitoneal lymphadenectomy. And they showed that if the aortocaval node is positive, then it doesn't help. And they have stopped doing it, although they were achieving R0 status. Second is HPD. Although HPD is achieving an R0 status, but because the cost was high, cost in terms of mortality, which was in double figures, and morbidity, and actual survivors were very small in number. In their last article, they have said that although technically feasible, it is oncologically unacceptable procedure. And as far as I know, they have stopped doing HPD for gallbladder cancer. And both these procedures were achieving R0 resection. And their point is that it is not only whether you can achieve R0 status or not, it is also the stage of the disease. Your comment on that?
When these HPDs or aggressive resections are compared, a lot of weightage was given to postoperative morbidity and mortality. So now, as of today, we can subject these patients for neoadjuvant therapy as well. And the morbidity and mortality has drastically come down now. So even if you reduce that morbidity, mortality effect on the earlier publications, what are today, these what we had that time, these patients, majority of the patients can eventually undergo a adjuvant therapy. So the difference between the that time and this time is very relevant. And those who stop doing aggressive surgery because of their evidence, they are not the people who are actually creating evidence now for aggressive surgery. It is the other people who are more conservative, started doing more aggressive surgery, and they are now the evidence what I showed also. It is from centers where even neoadjuvant therapy and adjuvant therapy were widely employed once upon a time. So we are slowly progressing there. In the lymphadenectomy front, I partially agree with you. An extensive parietal lymphadenectomy may not benefit. That I agree. But if you do a good number of lymph nodes excision of the intra-aortocaval front, it gives a very good staging. That's what my comments about that.
But I don't think I have seen any report from Japan or anywhere else of HPD for gallbladder cancer. After the last Nagoya publication, I don't think any center has reported HPD for gallbladder. So that was one point. Second point, when you said celiac lymph node dissection, conventionally we say, and I have also been teaching students, that you stay to the right of celiac axis, don't go to the left. So when you said celiac, did you mean a complete celiac node dissection like you would do, say, in a CA stomach?
So actually, what we do complete ciliary resection. The reason is in the lymph node front, we also put that margin. For example, how we technically ensure that the celiac axis right side is completely cleared with a very low morbidity and mortality, and compared to a complete clearance on the left side also. So technically, I don't find much difference in going to the left side, which creates more morbidity, and also we do a complete resection. And I don't find any clear evidence to show a watershed margin on the right side versus left side, especially in celiac area. So
But
even the ITO studies didn't show exactly the right side versus left side.
But
So
is there evidence, or in your experience, do you think that this complete celiac lymph node dissection will be helpful if the celiac node itself is positive?
no, celiac lymph node itself is positive. Maybe we do not have evidence for that. We need evidence for that if it is positive. Yeah.
Dr. Anil.
But
Yeah, maybe I can comment on this part. Biju, my understanding was that celiac lymph node, if it is positive, as you also said, then it is taken in a similar way as we talk about intra-aortic cave lymph node
that's correct.
or para-aortic lymph node, right? So what Dr. Vinay was talking about is that about the left or the right is because the right side, to what extent the hepatic artery node, etc., extends. So you are not sure that what is technically only a celiac artery lymph node. So that is why I think we all try to clear to the right side in the hope that we have cleared all those lymph nodes. And if there is something which is to the left, even if you cleared, but if it is positive, it is a bad prognostic indicator. So that is one thing. You can technically do it, and in the same morbidity is fine. And the second thing that I wanted to comment on was the HPD that Dr. Vinay was talking about in response to your statements. I think agreed that now it has fallen out of this thing after people showed the data in gallbladder cancer versus the cholangiocarcinoma. So cholangiocarcinoma, while still people do it, in CA gallbladder, it is very limited. And in that, two things I would like to add. One is that in some of the one which we also published, that if the pancreas is not involved or limited involvement, you can get away by doing a gastroduodenal resection in that area with or without a partial pancreatic resection, which has been shown by some of the Japanese literature, a comparison that the survival is comparable. Now, coming to the HPD, we have written in one of our papers also that that will be a spectrum. Like I would not shy away on doing an HPD if there was a fundic or a body tumor which was extending also into the pancreas, and I could get away with the segment 4B5 resection with a PD, because then the morbidity will be similar to a PD. And if I can ensure an R0 resection. So I think on one end of the spectrum is this kind of a patient, and the other spectrum is when you have inner cholestatic liver with or without decompression and needing a extended right hepatectomy or a modified extended right hepatectomy with PD. That probably would be having a much higher morbidity mortality. And as Dr. Vinay was talking about in terms of cost of morbidity and mortality, one may be very, 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 very selective in before you go on to that. So that would be my comment on this. Yeah. Dr. Vinay, would you want to respond to that?
No, that's fine. I mean, as I mentioned yesterday, also the SGPGI and at least my philosophy has been little conservative, especially with advanced gallbladder cancer. It was only during the time when Biju was with us that we did some of these major resections. Unfortunately, we have not been able to do a long-term follow-up of these patients in whom these procedures were done. But as I mentioned earlier, I am yet to see any report of HPD or an extended lymphadenectomy or a vascular resection talking of actual significant number of long-term survivals even after an R0 resection is achieved. So we probably need to wait for that evidence to come. But I don't know how many centers are doing it. I don't know if any center in India would have done more than 5 HPDs for gallbladder cancer to talk of any survival data.
I mean, in as regards the extended lymphadenectomy, I will just make one more comment that the way I think Biju was showing, I think most centers and we also don't perform an extended lymphadenectomy the way he showed it. The only thing is that periodic sampling or periodic clearance may add to the prognostic, and also now we in selected patients, even with periodic lymph node, we may go ahead and do a radical cholecystectomy, in which there is not need they are not needing an adjacent viscera resection and all. So if it is a low morbidity radical cholecystectomy, so that may be a bit debatable. But because with the improvement in the chemotherapy and with some series talking about reasonable survival even in those with periodic lymph node in selected group of patients, we may still do that. But for the postgraduates, and I think in exam also, it may not be a good idea to say that you will take up all these patients for resection.
No, but these are two different issues. One is that you do an extended chole even if the para-aortic node is positive. That is a non-curative intent extended cholecystectomy, and then you give adjuvant chemotherapy. What we are talking is that you do an extended retroperitoneal lymph node dissection from the crus of the diaphragm down to the aortic bifurcation, where you remove all retroperitoneal nodes. This is what Nagoya group used to do 20 years ago, but then they gave it up saying that it doesn't help, because if the nodes are negative, it is not required. If they are positive, it doesn't help.
So the second category, we don't.
Yes.
Yeah. That
Sadik,
extensive
any
lymphadenectomy.
comment on
Yeah.
Biju's presentation before we move on to your presentation, since you are there?
My philosophy is almost similar to SGPGI, and my way of thinking is we have been doing these because, as all the speakers are also saying, if the morbidity is less and technically it can be done. So many things now with the available, as one of the slides Biju showed, things have become feasible to do with minimal morbidity and no mortality. But I don't think any of us know what benefits it gives to the patient. So that's the only point. The point which Biju said, that once you do it, then only you'll know whether there is a benefit. And lymph nodal dissection, I think in all HPB cancers, we know that it is a extended form of staging rather than giving benefit to patients. So you should not understage the disease without doing a proper lymph node dissection.
So there is a question from Jasmeet Singh. What is the consensus on para-aortic node positivity? For exam purpose, is it resectable or does it preclude surgery considering it as metastatic disease? If you are asked this in the exam, you say para-aortic node positive is as bad as metastatic disease. It is a contraindication to resection. Once the examiner nods his head like this, then you can carry on and say, although recently some groups have adopted this concept of oligometastasis, which is there in other cancers for gallbladder cancer also, where these groups would include a small omental deposit which is close to gallbladder, single, a small liver metastasis which is within the area to be resected, and a para-aortic node positive. In that situation, one may emphasize the word one may, or groups are doing this kind of a resection if technically R0 resection without going through tumor is possible as far as the primary tumor is concerned. And as Dr. Anil and Biju mentioned, no major resections in presence of oligometastasis. Only so I'll give you an example. There is a small tumor in the fundus of the gallbladder with minimal infiltration of the liver, which will be covered in the wedge. But on staging laparoscopy, you find a single small deposit in the omentum, which is adherent to the gallbladder. You take it out, it is positive. There is no other disease. You do para-aortic node also, it is negative. So in some situations, groups have started doing it, but it is not a standard of care as far as management is concerned. Okay, I think we move on. Thank you, Biju. You can stop sharing your slides. Next speaker, as I have already introduced, is Dr. Sikora, my former colleague from PGI, SCPGI Lucknow, and now one of the leading GI HPV surgeons in Bengaluru. He is going to talk to us about another very commonly discussed both in theory and in practical exam and in clinical situation dilemma, that how to manage incidental gallbladder cancer.
Can I get a co-host this thing? I can't share.
Sadiq, you are a co-host. Please share now. Biju has stopped sharing.
It's still asking me who can share. Okay.
Are you using
No,
a
I
Mac?
got it. No, I got it.
Okay. Because yesterday TD
Can you
also
see?
had some problems. Yes, we can see. Yes. Please start.
Thank you very much. Thank you, Dr. Kapoor. And again, once again, it's always a pleasure to be on these forums to interact with all the listeners and share our experiences and thoughts on this. And we have a great group of people today doing this. So I've been asked to speak on reoperation for incidental gallbladder cancer. Now, this is probably one group wherein you can expect to do good for the patient. So as Biju said in his slides in the beginning, that there is one group which you can do well with surgery, and perhaps this is that group. And most of what I'm going to say is a sort of consensus on what a meeting which was held by Dr. Kapoor, wherein it was a consensus meeting on gallbladder cancer in Jaipur, I think a year and a half back. And we had a consensus meeting on incidental gallbladder cancer. And most of the presentation would include that. So that will be my reference source. So naturally, each time when we talk about it, we need to reiterate the definition of incidental gallbladder cancer. So the true incidental gallbladder cancer is those where pathology reveals a malignancy and there was no evident preoperative suspicion on clinical evaluation, imaging, and even at surgery. So this is important because incidental sometimes includes patients who we find suspicious areas on the examination of gallbladder after cholecystectomy, which on histology comes as gallbladder cancer. And generally, these are lumped together. So when you look at it, the incidence of incidental gallbladder cancer may be high, but true incidental, which is on pathology coming later, is lesser or almost half of what the true incidental is. In high incidence countries with gallbladder cancer, the true incidental is much higher than in low incidence countries. So there are actually two scenarios which you can see. One is a lady who's been operated for symptomatic gallstones. Surgery was uneventful, but on examination of gallbladder, there were some suspicious areas and frozen section revealed that it's a moderately differentiated adenocarcinoma. So the first question which one asks is, was there any way we could have predicted that this benign disease for which you're operating would have a possibility of malignancy? And there are some soft indicators for that. One of this is this Dutch prediction tool, which looks at age, sex, type of surgery, type of surgery in terms of emergency or open or conversion, and indication of surgery. And the scores have been given, and if the score is more than 7, the likelihood of it harboring incidental gallbladder cancer is high. Similarly, this other study again showed that open surgery, elderly female, Asian or African descent with elevated ALP may have a high incidence of incidental gallbladder cancer. So these are some pointers wherein in high incidence areas, you may look at these and wonder whether you may be dealing or may encounter an incidental gallbladder cancer. So if it is identified at frozen, I think there are two important decisions which one surgeon needs to take. If you are in a place where you can do an not do an extended cholecystectomy, then do not proceed any further. Document all the details and refer to a tertiary level center with the report, your operative report and HPE slides. And of course, counsel the patient and family regarding the findings. If you are in a place where there is facility and you have all the, if it's in a tertiary care center, what you need to make sure is the PT stage is well documented. You will obviously have to talk to the family and take their consent and review all the options in terms of doing the surgery at the same time versus revisit for surgery and what you need to do as an extended cholecystectomy, which we'll talk subsequently, what it is. What is interesting is immediate surgery at that point of time versus early revisit surgery, the data is inconclusive regarding which one is superior over another. So for all practical purposes, doing at the same time, vis-a-vis coming back, the outcomes are probably similar. And we need to remember that because sometimes patients are not prepared for this finding. And it's quite a shock for the family to see this and to agree for an extended procedure at that same time. This is the true incidental, that is, histopathology revealed the diagnosis, and this patient is referred to a tertiary center 2 weeks after surgery. And this is the more common scenario which we see most of the time. Now, in this, it is very important that appropriate information is gathered or supplied by the referring physician and surgeon. So you need to get all this information. What was the approach for surgery? Was it a conversion? On examination, was there any focal thickening or mass? Was there bile spillage? I think that's a very important point because 40 to 60% of cholecystectomies have bile spill. And if it is present, it needs to be mentioned clearly. Also, whether there is a complete cholecystectomy or a subtotal cholecystectomy, that needs to be mentioned. Where it has been extracted and whether it has been extracted in a bag or extracted through the port, just like that, because it is still a practice in many centers to remove the gallbladder without a bag. And in these situations, if now in retrospect, any evidence of suspected dissemination is there, should also be recorded by the referring surgeon. The histopathologist has a great role, and you need to get all this information of size, location, if possible, the cystic duct margin, and if the cystic lymph node is there in the specimen, is it positive or negative? And of course, the microscopic T-stage, histology grade, PNI, perineural invasion, lymphovascular invasion, as I said, cystic lymph node status, and margin status in terms of also now, more importantly, if it was on the liver side or the peritoneal side. Now, this is difficult to get because there was no suspicion by the surgeon during surgery. So the pathologist may have trouble finding out which side it is. But the serosal cover, if it is bereft of that, one can consider that it is in the area of the cystic hepatic bed. Always when it is referred, you have to send the slides and blocks so that the unit which is getting this patient can review this pathology report. Now, most of these patients would merit a staging prior to resurgery. And basically what it involves is doing tumor markers, doing a CT scan definitely, which includes a chest, that is thorax, abdomen, and pelvis CT. And there is a substantial group of people, I think you might have heard yesterday about Dr. Yadav, and a lot of people now are preferring to do a PET CT to document whether there is any disease which is residual or distant disease in patients with incidentally detected gallbladder cancer. You have some role of MR in terms of determining liver invasion or liver involvement and lymph node, and it may be selectively used. And of course, there is also a debate that when you do PET-CT quite early, you may have a doubt about the uptake, that level of uptake of FDG may also be a false positive because of the post-operative changes in the area of the cholecystectomy. But what is important is at least it would tell you whether there is any distant disease or not, barring a scenario where it is, say, a tuberculosis in mediastinal lymph node or some inflammatory disease. So a PET-CT may be valuable in test to do in the restaging process to be absolutely sure that there is no disease. And I'll tell one more reason when we come to that scenario. The second important thing after collecting all the information is what is the timing, best timing of resection in incidental gallbladder cancer. Now, a blanket statement could be that any time that the patient presents to you and having had a staging procedure does not show metastatic disease is a good time to do a reoperation in these patients. But interestingly, there are some publications which have looked at the timing and whether it has an impact on survival. And this study from Shah from United States has shown that surgery performed after 4 weeks has a better overall outcome. And a large series of incidental gallbladder cancer from Tata Memorial has also shown, surprisingly, that re-resection performed at 10 to 14 weeks has the best outcome. But as I said that, it is not prudent to wait this period and just wait for things to evolve. So as and when the patient presents, it may be a good time to do a reoperation, barring any reasons where you don't want to operate at that point of time. So as I said, no definite consensus when to do surgery. Best window has been this, but it should be offered at any time, provided all other situation is favorable. At resurgery, the approach is similar to what you would do in a primary gallbladder cancer. So you do a staging laparoscopy, you do a para-aortic or intra-aortic lymph node sampling and send for frozen. Disregard the discussion we had about positive and then what to do. It could be taken as what Dr. Kapoor has said. And if you have a prior histology which has shown that there is a tumor close to the cystic duct margin or cystic duct margin is positive, then you know that this patient may merit a bile duct excision. Now, the surgical strategy, irrespective of which situation you are encountering, and Biju alluded to this at that point of time, here we are fortunate that we have a histology, as what Biju was trying to say, that it's very difficult to do a preoperative assessment that it is T1A or T1 or T2 or T3. But after a histology, at least you are sure whether it is T1, T2, and so. The data suggests that if it is T1A or T1B, a cholecystectomy is adequate. A lot of groups would recommend doing extended cholecystectomy in T1B, but the data is quite clear that it doesn't matter in this group whether a cholecystectomy versus an extended cholecystectomy is done. The fact remains that in some studies, the disease-free survival was lower with lymphovascular involvement in T1B. So if that is present, it prognosticates a poor outcome. The most interesting group of patients in decision-making is PT2. And a googly has been thrown by the newer addition of PT2A and B, which is the peritoneal side and the hepatic side. So what is interesting to note is when you look at PT2A and PT2B, that is peritoneal and hepatic, the outcome of PT2A is better than PT2B, both in terms of recurrence-free survival and overall survival. The other point is of PT2A and PT2B is whether it merits liver resection, whatever type of liver resection we could contemplate. And it has been shown that in PT2A, it may not matter whether you do a liver resection or not, but PT2B, which is the liver side, the outcome is better when there is a liver resection. So in general, radical cholecystectomy is recommended in PT2 lesions. But in PT2A, which is the peritoneal side, perhaps, and I emphasize that perhaps liver resection may not be absolutely essential, as the outcome may be similar. But the lymphadenectomy is the key in PT2 disease. This is another large series of meta-analysis which shows that liver resection may not be an important component of PT2, especially PT2A disease. So there is debate on this, but there are data which is contrary to that as to the best procedure for T2 in terms of extent of liver resection. Lymph nodal metastasis is another interesting component. Now, as I said in the beginning, liver side fares worse than the peritoneal side, both PT2A and PT2 or PT3. But as far as lymph nodal metastasis is concerned, this very interesting paper has shown that the lymph nodal involvement is much higher when it is on the hepatic side as compared to the peritoneal side. And both the disease-free survival is also different in the hepatic side versus the peritoneal side. When you look specifically at lymph nodal involvement, it's again a very interesting data coming from this paper, which shows that when there is hepatic side involvement, be it PT2 or PT3, the incidence of skipped lymph node metastasis is much higher when the lesion is towards the hepatic side vis-a-vis the peritoneal side, be it in T2 or PT3. And you can see here the skipped node metastasis in PT2 is 0, whereas it is 15% in hepatic side, and it's 9% versus 55% in PT3. So what in essence it means is that in PT2 peritoneal side disease, if the cystic lymph node is negative, most likely the downstream lymph nodes are also negative. And in P, if it is hepatic side, the likelihood of skipped metastasis is high. So same thing, that the extent of lymph node dissection may be guided by this information that you have here. So this is a wonderful paper which everyone should read. It is a clinical practice guidelines by IHPBA and APHPBA. And this summarizes what we are talking about. So T1B and T2, your margin negative wedge resection is adequate. T3, no consensus, but it should be a negative wedge resection or bisegmentectomy. And lymphadenectomy, the extent of which we talked about, that basically it's hepatic artery, celiac, all the hepatoduodenal ligament along the portal vein, artery, bile duct, and superior, the retropancreatic and superior mesenteric lymph nodes. The next point is whether to excise port sites when you are reoperating for incidental gallbladder cancer. Now, the most studies have shown that excision versus no excision, there is no difference in outcome. There is similar distant disease or recurrence pattern, whether it is excised or not excised. A slight difference should be appreciated if it is an isolated port site metastasis with no evidence of any distant disease, wherein it behaves perhaps differently than the general port site metastasis. So a routine port site metastasis excision is not recommended. If you have to do in an isolated port site metastasis, generally, which is metachronous, with a long interval between the primary disease treatment and the occurrence of port site metastasis, then it should be a full thickness excision of the whole abdominal wall. And this can be either preceded with a neoadjuvant therapy or followed by adjuvant therapy. And as a matter of fact, because of that discussion in the consensus meeting held in Jaipur, a publication on meta-analysis and systematic review of port site metastasis is coming out from Dr. Kapoor's group. So the next question which comes is, what predicts survival in incidental gallbladder cancer? And this study says T stage, grade, lymphovascular invasion, PNI. And when you give these scores and you can segregate patients into low, intermediate, and high, you see that local recurrence and distant disease is highest when the risk is high, which is a higher T, higher grade, and lymph node, lymphovascular, and PNI positive. But the most important point is that any residual disease on resurgery portends a poor survival, irrespective of where the residual disease is, lymph node or in the liver. And the residual disease in the liver suggests a much poorer outcome than in the lymph nodes. The Memorial Sloan Kettering Group, in the quest to find out whether we can predict that there is any residual disease following a detection of incidental gallbladder cancer, they analyzed their data, a large number of patients, and on multivariate analysis, they found that T3 disease or poorly differentiated tumors were associated with very poor incidence of residual disease. And they did a CART analysis, which is classification and regression tree analysis, wherein you split the groups and look at in the binary fashion whether it predicts the outcome which we are looking at here, which is residual disease. So with T3, there is a very high likelihood of residual disease. With poorly differentiated disease, irrespective of T stage, it's about 2/3. And if it's T1B or T2 with well and moderated, the incidence is 35%, 1/3. So this gives you some idea of what it should be. How does it help? So I believe that we should consider neoadjuvant therapy if there is bile spill, high risk features, as I showed in the survival, that high grade with high score, PT3 and poorly differentiated tumors, or PET-CT showing residual disease. These may merit a neoadjuvant therapy. So the last slide is, these are modifiable factors. There are some modifiable factors in incidental GBC, but you cannot modify the histology. So the histology is what it is. But what you can modify is that whenever there is a suspicion, so in high incidence areas, or as we discussed that perhaps which suggests that these could harbor incidental gallbladder cancer, a meticulous surgery to minimize risk of bile spill, extract specimen in a bag, send all specimens for pathology, mark cystic duct end with a suture, and always don't miss to check the histopathology report. So this is the summary of it, that the incidental or early GBC has the potential for cure. Treatment options based on T stage are there, but there are many non-modifiable factors which determine the outcome. All should be offered resurgery. There is a debate on the timing, but I think that should be looked only in the context of whether the patients need a neoadjuvant therapy or not. Residual disease portends poor outcome, and we should consider in a certain subgroup a neoadjuvant therapy in incidental gallbladder cancer. Thank you very much. I'll stop sharing.
Thank you, Sadiq. Dr. Anil?
Yeah, thank you, Dr. Sadiq, for a very nice talk. And just a couple of things that I would want to, comment about. One is you talked about the timing of surgery. I think we also had analyzed our data. And even though like the Tata Memorial talked about the time gap of 10 to whatever number, 10 to 14 weeks or something. But I think this is one thing that in which you should go right away once you have got a patient back with a histopathology of gallbladder cancer, because the longer you delay, what we found in our study was that there were chances of unresectability increase, and also the magnitude of resection, because you were given more time for the recurrence to occur. So once you have diagnosed, once you have staged the disease, it's better to go right away rather than waiting. And probably, I don't know, I'll have to look at in the data in the Tata, group, is it that some of the patients were excluded because of the waiting period? That is one thing. Would you like to respond to that?
No, Anil, as you said, no, that uh, you should offer them after staging if there is no evidence of any disease per se, which is unresectable. They should be offered anytime they come, sooner the better. I think both for the patient and for the surgeon. I think the timing which people have looked at has various components which delays, either it is delayed referral or it is delayed due to some other reasons. And then we are analyzing uh, post, after that and coming to conclusions. I don't think it is reflective of actually the timing. It is just that patients who have come at that point of time and they were offered that. I don't think deliberately any of these groups have waited for that period to offer the surgery. So I think it's a post priori analysis and it
Right.
should be given only that much importance as it could be, saying again that even if there is a delay in presentation, they should be offered surgery.
Yeah, that is
Probably,
the important point I wanted to what you have highlighted, that it is in retrospect you analyze the data. But most centers you are advocating that they should go ahead and do surgery as and when the patient is fit for after you have done the assessment and all. And in this regard, also it is important when we read the incidental gallbladder cancer data, especially a lot of the Western series. I think I mean, or maybe from all across the world, because IGBC has been loosely applied, so they are not all truly incidental. Because some of the papers that you read, the incidence of residual tumor in the bed, so it will be very difficult to understand that if it is the truly incidental, which histopathologically should be early grade tumor, and if you have gone in and done a redo surgery early enough, then you shouldn't have a very high incidence of residual tumor. So I think that is one thing that one should analyze. And in the same light, I would say that port side metastasis, I think the lot of this thing was that Memorial Sloan Kettering paper. But if you see, there are fallacies of that paper, and in the sense that it is more like a statistical. In our part of the country, where it is not a routine practice in all centers to remove the gallbladder in a bag, we tend to have a lot of patients which are truly what you would call a port side metastasis, because by definition, again, port side metastasis when you do not have disease elsewhere. So I think probably if you have an isolated site and it is not part of the peritoneal dissemination, then there is a point in resecting that. And the other thing is, in the same with the same analogy, we as a practice would remove this port site in the completion radical cholecystectomy in most of the cases. Thank you.
So for the students, 2 points. One is that timing. I think for the exam, you should say that as soon as Dr. Sadiq said, as soon as the patient presents you with the diagnosis of incidental gallbladder cancer, you should investigate and offer the patient surgery. Because all these reports which say that survival was better in those patients who were operated after 4 weeks, some say after 10 weeks, some say after 8 weeks, they are all retrospective analysis. A new concept is coming in, although not standard of care, that if for whatever reason or as a policy you are waiting for such a long period, then you give some neoadjuvant chemotherapy, neoadjuvant before the completion extended cholecystectomy to these patients, which also gives you time to reevaluate the patient and see whether the disease metastasizes. The hypothesis of waiting to operate is that by waiting, you give the aggressive biology patients to show their aggression in the form of metastasis when you do a PET scan. But the standard of care is as soon as the patient comes and as soon as the patient is ready. One point about the port site metastasis, one has to differentiate between port site metastasis, which is because of bile spill and peritoneal dissemination, versus an isolated port site metastasis, or I would call it deposit actually, which is because of the port site contamination while extracting the gallbladder, and that usually will be in the port of extraction. Uh, in that case, if PET scan doesn't show any other disease other than the port site, there is a place, as Dr. Sadiq mentioned, for a full thickness down from skin to the peritoneum with at least a centimeter around that metastasis, because you don't know whether the port was placed directly or in a zigzag manner or in an oblique fashion. And most of these patients will then require some kind of a reconstruction, and the risk of incisional hernia is very high. But I'm yet to see a report describing a significant number of isolated port site metastasis excision showing long term, that is 5-year survival. So again, the same point.
So can I
Yeah.
just, I mean, in response to what Anil was saying, Anil, you would agree that you definitely don't excise all port sites electively to begin with. Is that true, or you excise all port sites?
Uh, you mean that in a completion radical cholecystectomy?
Yeah. Yeah.
Yeah, now we have become selective. Early on, we were removing all, and if it
Yes.
was an open cholecystectomy scar, we would excise that as well. But now we have become selective based on certain other factors. If we have some information like removed in a bag or not, if you have what is the T stage, and all those things. And so it is whether it is truly incidental versus the other one. So now we are selective and we're in the process of analyzing our data. And
So
to
what?
answer, yeah,
Yeah.
please,
Go ahead.
yeah, please.
No, complete.
No, please. You were saying
No,
something.
so I was just saying that perhaps routine port site excision is not a standard of practice at this point of time. Then I would think that the interval between port surgery and port site deposit or metastasis occurring would be an important component. If it is early, I would be more aggressive in trying to figure out whether there is any other disease. And these group of patients, I might give them chemotherapy first to assess their disease biology and then consider excision. If there is a metachronous one with significant interval between the primary and this, then I think there may be a point in going first for excision and then subsequent chemotherapy or so, provided that it is documented as an isolated port site metastasis. This is what I would think is probably the most logical way of going to it. I hope you
And in
agree.
the isolated port site metastasis that Dr. Vinay was talking about, we'll publish our experience. And we have had some reasonable survival, including not many, but including even 5-year survival. I think, which was again a selected patient that this 5-year survival was a 73-year-old lady. This was after an open cholecystectomy 2 years later. She came with this scar recurrence. So there were positive things in that patient. And we did all the imaging and there was no residual tumor inside. And she survived 5 years plus. But that is again anecdotal, I would say. But what we are saying is we have a few other patients which have survived 1, 2, 3 years. So probably what we are saying is that you should make all efforts to make sure that it is an isolated port site metastasis. And if that is the case, then one should go ahead and resect it rather than being thinking or presuming that most of them are part of the part of the peritoneal metastasis. And in this particular lady that I'm talking about, because she was 73-year-old, and what we decided was, so inside we went the lymph node for frozen section, and sorry, just one moment. And frozen section, and that was negative. We did not go ahead and doing the liver resection and the lymphadenectomy in this patient because we thought that if the residual disease inside, because she needed a kind of a mutilating surgery on the abdomen. So we thought that if it was a generalized disease, then we are not helping her. But if you are only removing that scar and she survived reasonable. So I'm just saying that one has to be a little open about and select your patients. That's the point I wanted to make.
Okay, I think let's move on. So next speaker is Dr. Usha Dutta. She is a physician, a gastroenterologist, head of gastroenterology at Postgraduate Institute of Medical Education and Research in Chandigarh. And she's made significant contribution to gallbladder cancer in terms of epidemiology. She wrote a very exhaustive review article on epidemiology of gallbladder cancer in India, which recently I received, because I was also part of that, a message from the journal that it has already had, I think, if I remember correctly, 30,000 page views. And Usha has done a lot of work in etiopathogenesis of gallbladder cancer also. And today she's going to talk to us about another very important and very debatable topic, how to manage asymptomatic gallstones. And this again is going to be important for the students from the exam point of view.
Thank you so much, sir. I'm just trying to share my screen. Am I allowed to share my screen, sir?
Yeah, we can see. It is there.
Um,
It is there already.
okay, perfect, sir.
Yeah.
So,
Just
good
put
af-
it in the presentation
Go to
mode, please.
go to the slideshow mode, presentation mode.
Yeah.
Yes, good.
Good evening. Thank you so much, sir, for having me here. I am an odd person out because I'm a gastroenterologist among surgeons and also being a lady, the only lady in the panel today. So it's very interesting that how in our country we are still caught up with managing CA gallbladder. Some of the other countries have managed significant progress in this. And let's see where we stand in India. Gallstones come in all shapes and sizes. All of you already know that. And it can have varying composition from cholesterol stones, especially in North India, to pigment stones, especially in southern part of India. And the color comes from white to jet black at the end of the spectrum. So we did an FTIR analysis and found that the color is a key indicator of the content of the stone also. It can be single or multiple stones. It affects both ends of the spectrum. It's not only the fat, fertile 40 females, it is also the young malnourished mothers who are having gallstones with them. And here we can, sorry, am I, just give me 1 second. I'll just share my screen again.
No, we are seeing your slide.
I think
Yeah.
the slide is not moving. That's the only thing. But the
Okay,
slide-
We are
yeah.
seeing.
So we see the fat, fertile 40 females as well as the young multiparous malnourished women of India, both getting affected with gallstones. And gallstones can cause acute cholecystitis, biliary colic, CBD stones, pancreatitis. We see more of this end of the spectrum. The surgeons see more of this end of the spectrum. So a 40-year-old lady, obese lady with 4 children, comes with postprandial pain after a heavy meal in the right hypochondrium or in the epigastrium, radiating to infrascapular region with nausea and vomiting, comes into the emergency, has an IV analgesic, ultrasound shows stones, and shows Murphy's sign positive or tenderness over the gallbladder. We diagnose biliary colic or acute cholecystitis, and we advise cholecystectomy. This is a clean, open and shut situation where there is no controversy. However, as we said, biliary pain could happen because of the stone, the cystic duct, or in the CBD, and we could have acute cholelithiasis with or without cholangitis. What happens with asymptomatic stones? 80% of the stones are asymptomatic, and the increasing chance of getting symptomatic with increasing age. There was a study called the Grepco study, which has been quoted ad nauseum, but however had very limited numbers and had shown a very small percentage of them go on to develop gallbladder related complications, and they suggested that patients will become symptomatic before they have complications. Because of this, it has been ad nauseum quoted in several guidelines that with asymptomatic stones you don't need to do anything. These patients will become symptomatic before they actually become complicated, and thus you don't do anything and tell the patient to go home and rest. And this has been what has been taught to us also as undergraduates, postgraduates. But however, when you start seeing patients, the scenario is slightly different. These patients can become asymptomatic anytime. We keep seeing patients with pregnancy and cholangitis, pregnancy and acute pancreatitis, and it is really hard to take care of 2 lives with the stone sitting there and causing trouble. Patients, when they are hiking, they are on air travel, obviously they won't be sent to space without an ultrasound and a cholecystectomy if they have to go to space. So it also in our country may present with gallbladder cancer as the first presentation. This is what is the most worrying out of all of them, apart from biliary pancreatitis and cholangitis. Cholangitis, fortunately, if these patients come in time, we are able to go in and immediately do ERCP and remove the stone, or just put in a stent, or if required, a PTBD, and these patients can be relatively taken care of. However, when they present with gallbladder cancer, it is a real difficult thing for the surgeons also, and you all just heard how difficult sometimes these patients can pose. There are several cohort studies in the West, none in India. And here we see that over 20% of them nearly in 20 years will become symptomatic. And please note that 8% will have complications. So it is the complications which are really worrisome. If they become symptomatic, we can take them up and do a cholecystectomy, but these complications are what are worrisome. And if you see patients who are having gallstones, a large cohort study, the Danish cohort study, 20-year-old follow-up, and you have uncomplicated colic in about 12%, CBD stone pancreatitis in 5%, and these can be very sick. And in India, it occupies a lot of our human resource, our ICU space, our resident time. So these are really, these patients also tend to stay for longer in the hospital. And it is not like the Western system where they have available beds and they have available system and resources to take care of these patients. And acute cholecystitis in about 3% patients. And in their study, they did not have gallbladder cancer. However, we don't have any data from India. We are right now doing a large cohort study to look at this aspect. What are the independent risk factors for developing complications or symptoms down the line? Is if there are multiple stones more than 1 centimeter, telling you that the stone has been sitting in the gallbladder for some time. Women are at 2 times more risk to develop symptoms. Younger age at presentation, they are again 2 times at more risk for symptoms. And older stones, that means larger stones and stones which we know are there in the gallbladder for a long time. In fact, yesterday only a colleague of mine who's an alumnus of PGI rang up at the age of 70. His now gallstones have started becoming symptomatic. So it is a very common telephone call I received, that it has been asymptomatic for a long time and now it has become symptomatic. So what are the options we have? We can do cholecystectomy. We can give ursodeoxycholic acid. We can do ESWL. We can just do a wait and watch policy. So what should we do is the matter of debate today. Surgery should be done if the patient has an associated gallbladder polyps, because these patients, we would like to have the gallbladder out. If there is associated gallbladder wall thickening, here you can see that there is a large stone in the neck and there is a thickened gallbladder wall. And these are patients who may have incidental gallbladder cancer. A good radiology prior to cholecystectomy is essential. And if the ultrasound is equivocal or by GB rads, which we have proposed, 3 or more, then these patients should undergo another cross-sectional imaging before they are taken up for surgery. There is no point going in and suddenly finding a malignancy there. It is better to pre-operatively assist these patients before they are taken up. So any gallbladder wall thickening should be held with suspicion. And this is where I send the case back to the radiologist to look at the gallbladder wall. Always I find that the radiologists tend to report the stones in great detail, but not the wall. So any asymmetrical thickening of the gallbladder wall should be held with suspicion. And nowadays we also have EUS to look at the gallbladder wall at a close position. So what we also have, if the patient has a stone and a suspicion of an incidental gallbladder cancer, obviously even if the patient is asymptomatic, should be operated. That goes without saying. And if you have an anomalous pancreaticobiliary duct junction, you can see that the CBD and the pancreatic duct, both of them are joining at the duodenal wall. However, more so in Japan and in Korea, we find that this pancreatic duct joins the CBD at an earlier point, and in these patients, the pancreatic juice refluxes back into the gallbladder, and this results in anomalous pancreaticobiliary junction being associated with increased gallbladder cancer. The cancer in these patients is slightly different. It is through the KRAS mutation, and it is due to repeated chemical irritation of the gallbladder. However, the gallbladder cancer that we see in our country is more like driven by bacterial infection as well as a changed microbiome and a chronic inflammatory state. And there it is more P53 driven. And if the patient already has a large stone, more than 3 centimeters, such a kind of stone should be better. The gallbladder is out. If there is associated porcelain gallbladder, there's recent changes in our understanding of porcelain gallbladder. Nevertheless, such a gallbladder has no business of staying in the abdomen. It might as well come out. If the patient is going to go to a remote area, definitely they should have their gallbladders out. If there's associated hemolytic anemia, the gallbladder should be out. If they are typhoid carriers, these patients have biofilms on the gallbladder stones, and you can never eradicate typhoid unless you take out the gallbladder. If there is a family history of gallbladder cancer. Now, this is a tricky situation in India because many patients do not know what actually happened to their parents when they are coming from rural or not so educated kind of communities. We do not know exactly what was the cause of death and whether they were harboring gallstones or gallbladder cancer, because many of the biliary symptoms are treated with ajwain and somf in India. So we really do not know whether the patient's parents died of gallbladder cancer. So is there a role of preventive cholecystectomy to prevent gallbladder cancer? This is a very provocative statement. I will just place my arguments in favor of it. Gallstones, is it an incidental or a risk factor? 80% of our gallbladder cancer have associated gallstones, 20% have without gallstones. The gallbladder cancer in both these conditions may be different, may have a different way of pathogenesis. In fact, Dr. Kapoor has been always telling us that we should be studying these two types of cancers and understand how different are they. So is gallbladder cancer a risk factor? And if we look at the Bradford Hill criteria, which says association versus causation, gallstones fit in all the components of Bradford Hill criteria, which tells us that it is really causative rather than just an association. There's sufficient experimental and epidemiological evidence. Gallstones increases risk by 7 times. A cohort study in Taiwan showed that the hazard ratio for gallbladder cancer among gallstone patients was as high as 58. And we showed that gallstone hastens the development of gallbladder cancer by 6 years. Gallstones, we all know, precedes gallbladder cancer, and there's a dose response relationship with larger stones, higher stone volume, longer duration, all associated with increased risk for gallbladder cancer. And 80%, as I said, in India have gallstones, and all young gallbladder cancer, we found that all of them have gallstones. We would like to hear the surgical experience in this area. So it satisfies the Bradford Hill criteria. And in India, we have to have our own policy because India is now the gallbladder cancer capital of the world, and we contribute to 10% of the global gallbladder cancer burden, and it's the commonest GI cancer among women in North India. And there's a north, south, east, west divide, and we find that the north and the east have higher incidence of gallbladder cancer, and the south and the west have lower incidence. And we are doing right now a study with ICMR to look at this divide and see whether the pre-malignant lesions in both the groups are any different. Once gallbladder cancer occurs, it has a dismal outcome. It really puts all our surgeons to test in order to ensure that the patients have a good outcome. And we have expert surgeons in our country, but it does take a lot of their time and effort to do that. That's because gallbladder is a thin wall. It is interrupted muscle, so the tumor gets into the surrounding areas very quickly, gets into the lymph nodes very quickly, and it's an anatomically very busy area. It has an aggressive tumor biology. Surgery is challenging, and there's poor response to chemoradiotherapy with a survival of less than 3 months. And this 3 months, I would say this is because a large number of our patients present with stage 3 or stage 4 disease. Obviously, the younger ones, the ones with incidental gallbladder cancers and T2 lesions may have a better outcome. So the common scenario is when a patient presents to me with multiple hepatic metastasis, there is a GB which is 3 into 3 centimeters, and the FNAC shows adenocarcinoma. And she was told 5 years back, you have asymptomatic gallstones and you don't need surgery. So this is the kind of patient I'm thinking about what we should be advising them on a long term. So could prior cholecystectomy have prevented this mortality? Chile has gone completely into preventive cholecystectomy. Anybody more than 40 years has a mandatory ultrasound. If they have gallstones, they are put on the surgical list. And in fact, they are overwhelmed with so much of surgery that many patients are waiting for surgery on that list. But they have realized this is the policy which works the best for us. Unfortunately, we in India, we follow North America and Europe rather than South America because of obvious reasons that we are more interested in what's happening to Trump and America rather than what's happening in Latin America. But it is Latin America which is more close to us in terms of our gallbladder cancer incidence. And Dr. Kapoor has been very closely collaborating with several people in Chile. So we need a strategy in India. Do we prevent it? Do we detect early gallbladder cancer? And do we do a wait and watch policy? Early detection has been fraught with a lot of difficulty. Japan did a study in 18,000 patients and did a house-to-house survey and found that early detection was not a cost-effective approach because it's very difficult in the presence of stones to pick up this early tumor if you're going house to house. So they dropped that idea, and wait and watch has its problem because that's what we have been doing. We have been waiting but not watching. So if we have to wait, we should be watching alongside. So our patients should keep coming regularly for follow-up. So let us explore what is the preventive strategy we should do. So this 30-year-old lady from Punjab comes for a routine checkup and has multiple stones. She's asymptomatic. In North America, they would have advised an expectant cholecystectomy. South America, elective cholecystectomy. In North India, we don't know what should be the advice. In South India, with low GBC, what should be the advice? We really don't know. So that's why we didn't have a cohort study or an RCT from India. And we, in fact, wanted to do an RCT, but due to ethical reasons, it was we preferred to take on a cohort study. So if you see, out of all patients with gallstones, only a very small proportion will develop gallbladder cancer over a 10 or 20 or 30-year period. But we really don't know who's going to develop. So that was the question. And the scenario in India is we have a high incidence of gallbladder cancer in contrast to the West. We have more risk factors and younger age of our population when they develop gallstones. So a longer time they are harboring the stones. So gallstone is an important target for prevention because 80% are having gallstones, and these gallstones are asymptomatic and they are easy to detect by a routine ultrasound. And we have a lead time bias of what 10 to 20 years. And strategy to wait for biliary colic and expectant management is one option, or we go ahead and do repeated ultrasound and pick up an early tumor and then subject them to surgery. So we did my student, PhD student did this work on, we found that mechanical injury, that means large, rough stones which were irregular, more often caused gallbladder inflammation. We found that stones harbored a lot of biofilms and a lot of microbiome was associated with these stones. We did a detailed 16S analysis of these stones and found that microbiota was entirely different on this stone. And the gallbladders which were harboring the stones were 80% of them had culture positive gallbladder tissue. That means the ones which are having stones already have a lot of bacteria sitting on the gallbladder lining as well as on the stones. And we found that chemical injury in the form of cholesterol stones were more likely to be associated with metaplasia in these patients. And gallbladder cancer goes through the inflammation, proliferation, metaplasia, carcinogenesis pathway. And we, in 225 patients we had studied, all had obviously cholecystitis. And we found that hyperplasia was there in 51% and dysplasia in 1% of patients. All our patients were younger. The mean age was about 47. So maybe if we had larger number of patients at the other end of the spectrum of age, we would have found more of dysplasia. And we found, however, preneoplastic lesions in the form of intestinal and gastric metaplasia in about 69% patients. Taking a cue from gastric cancer, where incomplete intestinal metaplasia is a risk factor for gastric cancer, we as endoscopists can keep going in and looking at this lesion. But however, with gallbladder, we can't keep going in. And we were finding that 141 out of the 213 had incomplete intestinal metaplasia, which puts them at 20 times increased risk. This is despite the fact that these patients were coming in for routine cholecystectomy at the age of 43 plus minus 14.66 years. So we are talking about metaplasia already there in the gallbladder tissue in a fair number of patients. So in the pathogenesis in India, we find that gallstones to metaplasia takes about 5 years. This is what the Chilean studies have shown. And once metaplasia happens, it goes towards malignancy in about another 5-10 years situation. And we found that 60% of ours had metaplasia. There's a study from AIMS which showed that 48% had metaplasia and dysplasia in 16% and CNC2 in 1%. They had an older age group of patients. So we often see patients in the age of 50 to 60 years, but if you go back in time, for 10 years minimum, they must have been harboring the metaplasia. And if we catch them at that time, we may be better off. So in India, we find that the metaplasia incidence is about 50%, whereas in Chile, it is about 50%, and in the West is only 5%. There was a study from Canada which showed that even at the age of 60 and 70, when they were resecting the gallbladders, only 5% had metaplasia. So we are already marching in that sense forward. And if we see the incidence of gallstones in the West is 15%, in India is only 5%. But you look at the gallbladder cancer incidence is very low in the West, but very high in India. So possibly this thought led us to believe that there may be cofactors in the pathogens of gallbladder cancer in our country. And several studies from our team, we identified typhoid carriers, H. pylori, poor socioeconomic status. A study from Dr. Jagannath from Tata Memorial showed heavy metals and pesticides. We found nutritional deficiency associated with gallbladder stasis, and gallbladder stasis itself associated with metaplasia, higher parity, and younger age at first pregnancy, all as risk factors to push this equation towards gallbladder cancer. We also found that there are several risk factors in our patients, and they are concurrent, and they are also additive in their action. So it is just like a young male who's 35, 40 years, who's also a smoker, who's also having family history of coronary artery disease, who's having lipids which are high. So that patient is at more risk for coronary artery disease. Similarly, in India, we have so many risk factors working against us and pushing the equation towards gallbladder cancer. So Indians are different. We are having high incidence of gallbladder cancer, high prevalence of risk factors, poorer nutrition, lower age at first childbirth, higher parity, more environmental toxins, more infections and genetic differences, poorer access to healthcare, and poor healthcare infrastructure. So just like people go to the Kumbh once in their lifetime, people come to a doctor also once from a remote area. And then if we send them home with the thing that you don't have to do anything about it, they're not going to come back to us without again coming back with some problem like complications of gallbladder cancer. So we need Indian data to drive Indian guidelines. Gallbladder, as we said, is very different. And now that with Ayushman Bharat and the cost of cholecystectomy coming down, we have sufficient expertise for lap chole in our country. I'm very much aware of the bile duct injury and the problems which we see of secondary biliary cirrhosis after the bile duct has been ligated. So definitely safe cholecystectomy is very essential. Dr. Sadiq and Dr. Kapoor have been great proponents of how to do a safe cholecystectomy. It goes without saying that if we do need to do a cholecystectomy, it should be safe. However, a study from Orissa has shown that in asymptomatic stones, cholecystectomy is far more simpler and easier than it is with patients who have had a cholecystitis and adhesions in that area. So we need to have our own strategy. And here we find that movement is life, stagnation is death. And similarly, in the gallbladder, we found that gallstone patients have lower gallbladder ejection fraction than patients without gallstones. So this is a large study in over about 700 patients at our center, and we found that the ejection fraction was lower in patients with gallstone patients. And we also found that those who had gallstones more often had intestinal metaplasia. So intestinal metaplasia, their GBEF was lower than those without intestinal metaplasia. And we also studied in another study with DBT with with the Northeast, and we did find that those who are H. pylori positive, seropositive, or having stool antigen or S. typhi, they had lower gallbladder ejection fraction. So maybe if many things are acting together, we are still trying to unravel that. And we found that those who are having H. pylori and S. typhi positive had lower gallbladder ejection fraction. We also found in pregnant women that those who were taking low protein intake had lower gallbladder ejection fraction, because Indian diet is very low in protein. We have always traditionally thought of fat as a stimulant for gallbladder, but actually it is a protein amino acid which also kicks in the cholecystokinin, and that is why emphasizing a good balance between protein and fat is necessary for the gallbladder to kick. If only people take fatty diet, which is very common in India, because fat is a cheaper source of energy than protein, and Indians being a large number being vegetarians, and even those who take non-vegetarian food can't afford non-vegetarian food on a regular basis, so they do have protein deficient state, and this may be one of the reasons why we are having more gallstones in our country for the amount of obesity which we are seeing, because there's an imbalanced nutrition. So this is study which we did in postpartum women, and we found gallbladder dysfunction very common. And in India, with age at first age at pregnancy being low as well as high parity, it is not surprising that we have so many gallstones. And we found that malnutrition is a risk factor for poor gallbladder function. So it is not just the obesity, but it's also the poor nutrition and less of protein intake, which is an important determinant of gallbladder function. So this is on multivariate analysis showing that protein intake is a dominant thing. You can see an R value of 0.726. So moving forward, so it is a combination. And as I said, even obese people having gallbladder dysmotility. So on both ends of the spectrum, we are having a problem of a metabolic disease. So what is the story in our country? We start with young women having gallstones because they undergo multiple pregnancies and they are in a nutrition deficient situation and protein deficient, fat excess situation, vitamin D deficiency, higher parity. And then we have infections also like S. typhi and H. pylori and low socioeconomic status with low antioxidant levels. And on top of that, if we have smoking and people coming from gangetic belts and pesticides in the diet, and with increasing age, we are pushing the equation to the right. So how can we unravel this? We have to ensure that we screen gallstone patients for gallbladder wall and look at the gallbladder ejection fraction also, and look for gallstones wherever before, just look for incidental gallstones. So this is what we are doing right now to look for and pick up asymptomatic gallstones, and watch out for gallbladder preoperatively at surgery and at histology. A large number of patients haven't even gone back to collect their histology, haven't met their surgeons. Have they met the surgeons? They don't pick up the histology, and this is a big problem. And histopathologists also just take two standard tissues in the block and report it as cholecystitis. So they also tend to miss incidental gallbladder cancer. So this is a big problem in our country. We have to standardize. And now that we have surgeons here, my request is that we make a single page, cholecystectomy checklist, pre-op, operative and post-op, so that even whenever a patient gets operated anywhere, comes to another person, we know exactly what had happened. So what are the high-risk gallstones? Multiple stones, stones more than 20 years, stone volume more than 6 ml. This is a Chinese study which has shown age more than 50 years, higher parity, typhoid carrier state, H. pylori positivity, gangetic belt, low socioeconomic status, smoking, GB stasis, and GB polyps. So all these are high-risk red flag signs. Obviously, large number of patients may fall into this, and we have to see either we offer preventive cholecystectomy, a close follow-up, and a careful evaluation of the gallbladder wall. So what are the risk factors? I'm just summarizing it here. Host factors, if we already discussed low socioeconomic status, I'm saying this again because these are patients who are nutritionally deficient. These are patients who have low immunity. These are patients who cannot access medical care again and again. So if I see a lady who is more than 50 years, has stones, comes from a low socioeconomic status, from distant places, from Himachal Pradesh, I usually tend to offer them cholecystectomy. And we also saw the caveats with family history being positive or negative. And when I look at the gallbladder, I look at stones, look at the multiplicity, and if I think it's a long standing stone, if there is associated mirices or porcelain gallbladder, and if there is anomalous pancreaticobiliary junction, which if it is incidentally picked up, nobody goes on looking for these because it's not possible to do an MRCP in all these patients. And if there is a CBD stone, obviously, even if it is asymptomatic, the gallbladder should be out. And if I find gallbladder stasis, which we do routinely in all our patients with gallstones before they are sent in for before we can plan our management. And infections like S. typhi and H. pylori, irritants, and heavy metals and occupational exposure, all these also increase risk. So this we published as a part of the study, which Dr. Kapoor already alluded to. So the story is that we have gallstones, mechanical bacterial chemical injury, chronic inflammation, metaplasia, dysplasia, carcinoma, and an advanced malignancy and dismal outcome. We would like to stop the story here. So ursodeoxycholic acid is an option, but it's not very effective. The stones come back. If it has to be given, it has to be given as 300 milligram thrice a day with meals. And the cystic duct has to be patent, the ejection fraction has to be good, and it should be in the absence of calcification. So we don't routinely advocate ursodeoxycholic acid, except if the patient is waiting for surgery, we would like to give it at that time. ESWL used to be used as an option. Nowadays, we no longer use it because we have several methods to handle CBD stones. It was primarily brought in with CBD stones, large CBD stones in mind, but nowadays we have other methods like laser lithotripsy to handle these large stones. Wait and watch in whom? If the person is asymptomatic, has a good ejection fraction, is motivated for follow-up, belongs to a good socioeconomic status, and educationally you can contact them, and they have a gallbladder wall which is less than 2 mm. The traditional teaching has been 3 mm, but we find that normal gallbladders are usually 2 mm. So anything going more than that tells you that the gallbladder has started getting inflamed. So wait and watch. Meanwhile, ask them to take small frequent meals, ensure that the function is adequate, avoid prolonged fasting, followed by a heavy meal. This is something which I tell my patients always, and stay closely monitored for gallbladder wall symptoms and ejection fraction, and get a lab chole if symptoms develop. So we have already discussed all these components. All I would say here is that if the patient develops symptoms on follow-up or gallbladder wall thickness goes more than 3 mm or the ejection fraction is less than 40, I would prefer to undergo a cholecystectomy with this kind of scenario. So these are our previous publications in this area, and this is the team with which we have worked. Thank you so much. Thank you.
Thank you, Usha. I would like to sound a differing note. You said that uh, gallstones qualify all the Bradford Hill criteria and they do cause gallbladder cancer. But as you yourself mentioned, gallstones are so common in the US, but there is no gallbladder cancer in the US except at MSKCC or maybe MD Anderson. No other center reports a series of gallbladder cancer. So it is not gallstones, it is something else. Something else, we don't know whether it is genetics, we don't know whether it is environment in the form of infections, pesticides, heavy metals, aflatoxins, whatever. In India, APD-BDU is not a common thing. It is probably in East Asian population because there the gallbladder cancer without stones is more common. So I am not convinced, and that is what I preach and practice also about the role of preventive cholecystectomy in every patient. And I don't think we have data from India to say, because all these metaplasia and other changes you showed in symptomatic stones, isn't it? These are patients who were operated for symptomatic stones. There is no series which shows histological changes in patients who, for whatever reason, have been operated for asymptomatic stones. And therefore, my philosophy is that I do not advocate preventive cholecystectomy for asymptomatic stones, but knowing very well that this fear of gallbladder cancer may be there in the mind of the patient, if the patient asks for it, if a patient with asymptomatic stone comes to me and wants a cholecystectomy, I don't refuse it. Of course, all the students must be aware that this has to be done with proper counseling, with proper documentation, because the expected benefits are remote. They may or may not happen after 20, 30, 40 years that you are preventing a gallbladder cancer, but the definite complications will happen in the immediate post-operative period. So you have to be very careful in advising or doing a preventive cholecystectomy, and this cholecystectomy has to be more than 100% safe.
Entirely agree with you, sir. Absolutely, it is right. The fact that you have said that the cholecystectomy should be 100% safe. There is no 100% in medicine, but I would say 99% safe. Uh, the gallstones in the West are not associated with gallbladder cancer for several reasons. One is that uh, there is very low incidence of the pesticides. Like Europe has zero tolerance for aflatoxin. If any peanut packet has aflatoxin, even 1 part per million, that thing is dumped. In India, we do not know what is the aflatoxin level. We recently have just published role of aflatoxins in gallbladder cancer, and large number of our patients had higher aflatoxin compared to the patients with just gallstones compared to those with normal controls. The second issue is that the stones, whichever we studied, we found that they had biofilms on it. They had bacteria on it. Stone cultures were positive. The gallbladder tissue in these symptomatic patients were positive for bacteria. And what is symptomatic stones? If we look at it, from what we have understood, symptomatic stones, one episode of abdominal pain, which is typical of biliary colic, makes it symptomatic. Now, what happens physiologically in a symptomatic gallbladder means that stone has gone to the cystic duct and fallen back into the gallbladder, may have had transient obstruction of the gallbladder, and that is what makes it symptomatic. Just one episode. So, there we are doing a cholecystectomy to prevent further symptoms. But physiologically, pathophysiologically, what has happened is just one episode, one stone has gone from the fundus of the gallbladder, sat at the cystic duct for 20-30 minutes, caused some transient obstruction, and fallen back here. And but will that change everything? I don't think so. And quite often, many of our patients, have epigastric pain. They take something, household remedies or some Digene and PPI, and we really don't know whether they had symptoms or did not have symptoms. So just on that one little abdominal pain lasting for 30 minutes, we are taking all the call. I agree with you. Asymptomatic stones, we do not have data, and that is why we are doing a large cohort study with ICMR to follow up asymptomatic stones and see what is actually happening to them. And we would welcome all our surgeons if they do operate asymptomatic stones because of patients asking for it. Please, we would like to look at those gallbladders and look for metaplasia in them. And if we do find metaplasia in them, our debate rests. But if we don't find, or to a lesser extent, then the debate is on. So I do think that if surgeons from our surgical colleagues, if they can help us and give us asymptomatic gallstone tissue, and in fact, right now the study is with SMS Jaipur, and I have a person there, Dr. Gaurav is doing. He can come across to Mahatma Gandhi and pick up these gallbladders, and we can look at these gallbladders for metaplasia. So I do think that we cannot make a statement right now because we don't have data. I'm just provoking our thought process to think differently. Thank you, sir.
So we have just 5 minutes, 1 minute comment each from Dr. Anil, Dr. Sadiq, and Biju,
Yeah.
and TD.
Thanks, Dr. Usha, for a very nice presentation. And as you said, as a female and a gastroenterologist, as an odd man out, I think it's not odd odd women out, but it's you are providing the completion to the whole seminar or the symposium. And the thing is that probably, maybe for the same reason, you have taken a lot of liberties in trying to, as you said, to stir the surgeons. Because on one hand, you are saying that you can perform a safe cholecystectomy, which is 100%, and you quote a data to say that less than 3 months survival in gallbladder cancer. Times have changed, and I think it depends on at what stage the cancer is detected. And I'll just counter, because I have only a minute, the two things. One, as Dr. Vinay Kapoor talked about, because one cuckoo doesn't a summer it makes. You have talked about negative effects if you leave the gallbladder behind and turns into a gallbladder cancer. I mean, we are aware of so many patients in which a cholecystectomy has been done, even in asymptomatic, with disastrous complications, right? So that has to be kept in mind. And the other thing is, when you talked about, like, say, pesticides. Now, pesticide, they enter the gallbladder even in those without stones. So, do you, I mean, are you recommending that because gallbladder cancer is so common and the pesticides, do you say that in southern India it is not there and in northern India it is there? Then either, like, you don't do hysterectomy for preventing cervical cancer. So now the point is that, are we recommending that, because we know that a lot of gallbladder cancer occur without gallstones? And if the thing is that it is a pesticide, and some of the things I would question, again, I'll just move on, is that what you talked about, a simplistic model of saying how gallbladder cancer occurs in India is different from what in Japan. Like APBDJ, it's not that we don't see. Anyway, I think I've had my 1 minute, so I'll pass on the.
Just a quick thing, sir. The fact is that with stones, the gallbladder function also goes down with time. So the gallbladder is not able to empty the metabolites which are getting secreted from the liver. So we have to also understand that bile is an excretory product of the liver, just like the urine which is produced by the kidneys. So here the metabolite then accumulates because of stasis, and then can set up a problem. So stones also is associated with inflammation and stasis. So I think it's a combination of a potpourri of things which is happening in the gallbladder microenvironment. I agree with you. All patients with pesticide exposure need not have.
We have only 3 more minutes. Sadiq.
Okay, done.
So,
Dr. Sathik wants to say something.
no, I just want to say that it's a slippery slope on which we are. I think recommending for all is a very drastic step. We probably need to refine the uh, selection process of whom we should offer cholecystectomy in that. And I'll tell you what Anil was saying. I have at this point only 2 patients in the space of 1 month. One talking to the hospital that why you did not recommend a cholecystectomy 10 years back when I had a 5 mm stone and now it has become 1 centimeter, although he has no symptoms. And on the other hand, there's a patient who who had asymptomatic gallstones, who had a bile duct injury, which we repaired. And he says, was it really required when they offered me a cholecystectomy? So we still have these scenarios going around, and the recommendation has to be really, tempered rather than all-encompassing to remove all gallbladders. Thank you.
Just to clarify, I did not say that all asymptomatic stones should be out. These are the risk factors. If the patients come from a high risk area, family history of gallbladder cancer, or they are having large stones and they're having stasis, this is a subset of patients. I'm not saying all patients need to
TD Yadav.
a cholecystectomy.
TD.
Yes, sir. Good evening, sir. Just I was listening. I don't have anything to say.
Biju.
Good evening, sir.
There are several countries in the world where gallstone disease is common and cholecystectomy is the commonest surgery and gallbladder cancer is rare. One example is Kyrgyzstan, where gallstone is the commonest problem there, but gallbladder cancer they very rarely see. Yeah.
Yes, I agree with you, Dr. Biju. In fact, we have, that is why I said it is the associated cofactors which are the drivers. And maybe stone plus cofactor is worse off than just the cofactors or stone alone.
So students who are watching and who are going to watch this program, if you want to read more about asymptomatic gallstones, please send me a mail, vkkapoor.india@gmail.com. my colleague, Dr. Anu Bihari, who is now the Chief of GI Surgery at SGPGI. We have written several articles and book chapters on this, and hopefully they will give you some more information. And more than, I mean, Dr. Usha has given a lot of information, but they will probably give you hint as to how to handle this question when asked in the exam, both in theory paper and in the clinical viva voce. So we are at 9. Thank you, everyone. Thank you, Dr. Anil Agrawal, for co-moderating both days, in spite
My
of you
pleasure.
not keeping well. And thanks to the speakers, Sadiq, Biju, and Usha, and thanks to Dr. T.D. Yadav for joining today, although he was not a panelist today. And thanks to Avinash Tank and his team of Pinesh and Himanshi at Dwarka Clinic in Ahmedabad, which, as I mentioned earlier, offer all the IT assistance for all our online educational activities. Thank you all very much. We will close.
Thank you,
Thank
sir.
you. Good
Thank
night.
you, sir. Good
Thank
night,
you.
sir.
Thank
Good
you.
night.
Good night.